In the interest of time, it's wonderful to listen to Nora Jones, but we're here to have the postgraduate course on SAGES Smart, incorporating the latest enhanced recovery into your GI program. My name's Raj Agarwal. I'm a surgeon at McGill University. My co-chair is Carmen Mueller, also a surgeon at McGill University.
Good morning.
And we're really grateful to have you here. Hopefully the room will fill up a little bit more over time. This is really a very exciting course in terms of we know a lot about enhanced recovery, and a lot's been written in the last 20 years, and it's really taking traction now in terms of getting incorporated into a number of programs. And obviously it started with colorectal surgery with the work of Dr. Kellett. But really what we want to talk about today is the first part of the morning session is really about the implementation, and we have some great speakers to talk about that in terms of the barriers, in terms of the enabling factors. We know it's a good idea, so how do we actually get this into practice? So we have a number of talks this morning on that. And then the second half of the morning is very much on really, when Carmen and I were putting this together, thinking about how far can we go with enhanced recovery? What are the areas? I mean, is it appropriate for every single surgical patient? And so what are the emerging ERP care pathways that are being involved? And then after this afternoon, we have a session that's run by Dr. Senegor and Dr. Boutros, which is very much about bringing your team together, and really a workshop where we as the so-defined experts are going to talk to you about these kind of barriers, enabling factors, implementation, and so forth. So that's really the background, the overview to what we're going to do over the next few hours today. Carmen, if you want to add anything.
No, I think that covered it. Yeah.
Great. So just to kick straight off, we're going to get an overview of a program which is becoming more and more mature now, the SAGES Smart program. We have Dr. Feldman, who's going to talk to us about that. Dr. Feldman is a professor of surgery and chair of the Division of General Surgery at McGill University, and really has been the leader of this SAGES Smart program. So thanks so much, Liane. Really looking forward to hear your overview.
Thank you.
And just one second, sorry. Just one other thing. Liane has to rush off to the board meeting, so we're going to take questions right after Liane's talk. So if you have questions, you can have them ready right after Liane's talk, and then we'll have the panel session after the next few talks after that. Thanks.
Well, thank you, and good morning, everyone. Thank you for getting up bright and early and on the Wednesday of what's going to be a great SAGES week. It's a really great program, and it should be a really fun week. I'd like to talk to you about SAGES' take on enhanced recovery called SMART. My disclosures would not be relevant to this talk. So why are we here? If we ask ourselves, we're here at SAGES to learn about new techniques in minimally invasive surgery, to refine the techniques that we already know, to see what's coming on the horizon. And we're here because we're dedicated really to providing what state-of-the-art surgical techniques and advances to our patients. And the question we also need to ask ourselves is, as the rest of our perioperative care, what we're providing to our patients, has that kept up with what would be considered state-of-the-art? If we look at the negative impacts of surgery on our patients related to some of the metabolic and physiologic responses to surgery, we've approached that as surgeons interested in minimally invasive surgery as the main strategy to impacting that, and with the expectation that that's going to improve recovery for patients. And certainly it has many benefits on inflammatory response to surgery, but it hasn't been the only answer. And in fact, recovery and complications still occur at relatively high frequency and higher than we like. And what we need to be aware of is if we only focus on what happens in the operating room, then even if we do the most perfect operation in the world, which of course we all do all the time, even if we did that, we still won't maximize the benefits of these new approaches for our patients. There's been a lot of evidence coming out of different areas in anesthesia literature, even nursing, education, patient engagement, technology, about other techniques and strategies for improving surgical stress response and improving recovery for patients. These include innovations in afferent neural blockade. These include pharmacologic interventions, including things like IV local anesthetics that are very effective. They include other interventions like paying a lot of attention to fluid management, temperature, carbohydrate manipulation, and even things like physical activity. And if we don't attend to all of these things as the leader of perioperative care for our patients, at least our patients look to us as to lead that process, then I think that we're not maximizing what we can do in the operating room. Now, this is very small on purpose to say that, and the reference is there, that if you look at evidence, and this has been accruing over the last 25, 30 years, for guidelines, best practices, best evidence in perioperative care in multiple procedures, so I just picked two, colorectal and upper GI and lower GI surgery, at least 20 components, involve multiple stakeholders. Some of the examples are laparoscopic resection, okay, good, most of us are good with that one. But then when we look at the other components across the entire trajectory of care, for example, duration of preoperative fasting should be 2 hours for liquids and 6 hours of solids. That means that our patients, the recommendation in guidelines should be that our patients shouldn't be fasting, and I'll get to that back in a second, and even receive carbohydrate loading, not to use NG tubes. This is also after upper GI surgery. So most of us, we've abandoned NG tubes after bariatric surgery, even though we're doing almost an esophagojejunostomy, but still, if we're doing a gastric section for cancer, all of a sudden that patient has an NG tube for often several days. These are some of the traditions that we have. Fluid balance, so recommendations for, about the amount of fluid that patients should get and paying attention to that. Immediate nutrition, even after upper GI surgery. Again, we do it in bariatrics, but for some reason, we don't do it after esophagectomy. I'll give you an example of how we have a lot of evidence, but evidence is not enough to change practice. We all know that. Preoperative fasting, that's one of the most commonly performed interventions for patients. Maybe you can raise your hand if the last patient you operated on was MPO after midnight. So it's the vast majority of people, besides the few speakers who maybe have changed their practice, but this is very, it's almost religious practice over the past 50 years. And it's got a good rationale. It's not that this is a bad thing. This is just that nobody wants their patient to aspirate. This is a textbook truth since the 1950s. And it makes sense. There's a good rationale. You're going to induce general anesthetic. Our patient should be MPO to prevent aspiration, a terrible, devastating complication. But of course, there's a downside to that, and we have our patients with long periods without hydration or nutrition. And if they're MPO after midnight and you're doing your lap chole at 3 p.m., then they've basically been getting into a metabolic state that is very different than the fed state. And there's a lot of evidence that have addressed this. This is a Cochrane review. It's already getting kind of old. There's 22 RCTs in that Cochrane review, and they conclude that you can reduce the period of fasting to 2 hours for clear fluids without increasing risk. In fact, anesthesia guidelines from all over the world have said the same thing for almost 20 years. So it's not that there's no evidence, and it's not that there's no guidelines, and it's not anesthesia. It's that these are out there, and we have trouble getting these into practice. And in fact, most of us who would be going into a physical challenge would, in fact, make sure we had enough carbohydrates on board, and in fact, around surgery, there's probably at least a metabolic benefit in preserving insulin sensitivity when patients have carbohydrate loading. So not only is fasting not beneficial, it also might be not allowing us to provide a beneficial intervention, such as carbohydrates. So who's going to go home and write this instead of MPO after midnight, allow solids up to 6 hours pre-op, allow clear fluids up to, and in fact, let's give them some apple juice, 50 grams of carbohydrate. So who's going to leave this course and do that? 0 people? Oh, 1. Okay, 2. But most people don't do that because what's going to happen is what? Case is going to get canceled. the case is getting canceled, you're never going to be able to write this, the case is getting canceled, everyone's going to go crazy. Which is why the thing is that we work in silos. We work in anesthesia silo, we work in surgery silo, we work in nursing silo, and the patient is the ping pong ball that goes between the silos. And SAGES is an innovative surgical society. Debbie Keller is a speaker here. This is data she's going to show in a poster, and this is just a small piece of it, so I don't think I'm preempting anything. But if you look at a survey that she did of SAGES members about their compliance or adherence with some of these recommendations as what I would think an innovative, forward-thinking surgical society, okay, laparoscopic approach, got about this for colon surgery. No NG, 80%, meaning that some people in our society after colon surgery are leaving an NG tube. We know there's a lot of data about that's not helpful. Fluid management, 50% said they do some intraoperative fluid management. Feeding patients immediately after colon surgery, a lot of data that is safe. We have about 40% of people saying they're doing that. Of course, the fasting, we had about 25%. So this is compliance with data and guidelines that have been there for a long time. What day do you tell patients to be discharged after colon resection, uncomplicated colon resection? So raise your hand if it's 1 day. So nobody. 2 days? Couple people. 3 days? Couple people. 4 days? Couple people. 5 days? No? Okay, well that's about what most SAGES members say, 3, 4, 5 days. In fact, the median length of stay in the United States, according to NSQIP, so that's colorectal specific people interested in colon surgery, is 5 days. And look at that distribution. That's uncomplicated colon surgery. So there's something about organizing care, and there's something about getting evidence into care, and there's a lot of variability in what we're doing, and this is the NSQIP data. But the good news is that if we want to improve this, the fact is that quality programs are not because we don't want to do the right thing, and it may not even be because of knowledge. Many of us may even be aware of that knowledge, but we feel it cannot be done for whatever reasons. Our cases are going to get canceled, or for a lot of different reasons, or even because of resources. We devote a lot of resources to healthcare quality management, risk management, all those things. But so it's not really that we don't know or want to do the right thing, but it's because of problems with the way care is organized. And that's really what enhanced recovery pathways are all about. And these are also known as ERAS, and SAGES version is called SMART. This is evidence-based. It's multidisciplinary, so all the stakeholders involved. It's an integrated pathway that covers the entire trajectory of perioperative care. A consensus, meaning we should all be able to get together, at least within an institution or even as a society, people interested in treating a particular disease or providing a particular intervention, and in looking at the evidence and coming to a consensus of what the best practices are, at least at each institution, so that everybody doing right hemicolectomy is, from surgery, anesthesia, nursing, is going to be providing, I'm not saying how you do the operation or how you do anesthesia, I'm taking the easy stuff, not even the hard stuff. The easy stuff, like when we feed patients, how we move them around, and when they're going to expect to be discharged, and what kind of instructions we give them, we can come to consensus about that. To basically support normal functioning in our patients and earlier return of functioning through the reduction of physiologic stress, but also through just some of the things are just organizing things a little bit better. I learned a new word this week, I think, in reading a paper. There's a lot of interest we want to innovate, meaning we want to bring useful new practices to our patients, but we also have to learn how to exnovate, meaning that we have to stop doing things that aren't useful in order to improve outcomes and costs and decrease some of that unwanted variability. And the idea here is to get rid of the patient being the ping pong ball that moves between the different providers and the different interventions, and instead reorganize all these different evidence-based interventions around the patients in preoperative setting, intraop, and postoperative. As Raj mentioned, this a lot came out of the work of Professor Kellett in Copenhagen, who, I don't know if you remember this paper, maybe it's not 20 years ago or 30 years ago, but it's 15 years ago. I remember reading this paper and being really, really blown away by it, because this was a paper that in the annals that described 60 patients, they're 75 years old, 74 years old, having open colon resection, and his accelerated multimodal rehabilitation program, which really had a lot to do with thoracic epidural, early feeding, and mobilization, and he reported median length of stay of 2 days. This was like a crazy, crazy paper that people thought he was lying or not exactly reporting things correctly, or that patients in maybe Northern Europe are different than our patients here. And so this was, for a lot of people, really shook things up. Since then, there's been a lot of trials, so 38 randomized controlled trials in this area. And now not just in colorectal surgery, although a lot of the work is in colorectal surgery, but also in upper GI surgery, urology, orthopedics, and thoracic surgery, that all show very similar effects. And when you put them all together, this is a meta-analysis showing a decrease in about a 30% decrease in the risk of complications without any increase in major complications, and also concomitantly a decrease in length of stay, which should result from reorganizing care, but also if we can improve some of these complications without any increase in the risk of readmission. So that's a fairly consistent effect across these studies, although different in the magnitude of the effect. And we're also going to talk in this session about the business case for getting the resources to help set up these kind of programs. Now, what are the interventions that are the magic interventions? What are the interventions that are completely necessary to have in your program? If you look at different, just from a systematic review, different interventions, and there are a lot of differences, and some programs have a lot of interventions and some have fewer interventions. Some of the ones that I think are probably some of the key elements are engaging patients and having daily plans and daily care plans for patients, preserving nutrition by shortening fasting and getting patients eating immediately after surgery, increasing and maintaining physical activity before and after surgery, laparoscopy, avoiding fluid overload in patients, minimizing opioids, various interventions, and removing a lot of the tethers that we have on patients, so getting the drains out and getting the IVs out very, very quickly. But really probably the magic sauce in it all, and it's not one intervention or the other, but the key thing is this multidisciplinary approach. Before we started our program, and with Dr. Carly, who's an anesthesiologist with us, and who's really been a real expert in prehabilitation and preparing patients for surgery, until we developed this team at our place with nursing and nutrition and physio and pharmacy and a medical librarian to help us with evidence searches. I had never gone to a meeting where I really spoke to anesthesia and nursing in a standard way about how we were taking care of our patients. Maybe other places are different, but that just wasn't a group that I was meeting with, which is sort of funny when you think about it. And when I tell people, non-surgeons or non-medical people about this kind of work that we're doing, they're like, well, duh, I mean, right? You're all taking care of the same patient. You mean you guys never talked about it before? So it seems funny, but it's just not the way that we tended to work together. And the way that and so this getting your team together and who's on the team and may differ between different places, how often you meet may differ between different places, but the idea that we're all coming together to come to some sort of consensus to apply this evidence and make it happen for our patients having the same procedure is I think the main intervention that you're doing. And in our place, we've been able to apply this to colorectal surgery, but then apply the same principles to basically many different procedures. It's all the same kind of idea of trying to review the evidence, try to apply it in a way that makes sense for us, and going through the same process of having standard patient education, standard patient orders, standard medical orders, care plans for patients so they know what's happening every day. And you can apply this for basically many different procedures, and we'll hear examples of that. And in our place, we have at least 1,500 patients a year. All the patients having these procedures use these pathways for their perioperative care. We've spent a lot of attention at our place on patient education. You can see all of these at this website. muhcpatienteducation.ca. These are PDFs. You can download them and you can see if they would be useful for you. Basically, they're a graphic representation, a patient version of the care pathway. For each procedure, we make a patient version of the care pathway that has basically the steps that patients, what's going to happen for them every day in terms of physical activity, pain control, nutrition, and tubes and drains. So they can be much more involved and proactive in understanding what's happening. The big barrier is about implementation. So this is just another course, and this is just another package of information coming at you, and another bit of evidence that is hard to get into practice. So the question is, how can you go home now after this course and, if we do a good job, convince you that this is a good thing to do for your patients, and then look at the blank computer screen and it's then not be able to do it. And that's really what we're trying to help with the SMART program. SAGES SMART is our version of an enhanced recovery program. The mission of the program is to help promote adoption of enhanced recovery care principles as a cornerstone, really, of minimally invasive surgery in order to further improve safety, efficiency, and outcomes of GI surgery. This is a program that is available through the SAGES website, but you don't have to be a SAGES member to, if you Google SAGES SMART, you will get to this webpage. This is this is just the SAGES webpage, and you can click to find the SAGES if you are in the webpage, or you Google it and you will get there. Basically, what the webpage, what the program shows you, if this works, sort of, yes. This is a pretty generic pathway for bowel surgery. It would be applicable to colon surgery. It would be applicable to abdominal wall reconstruction or bowel surgery generically. It basically talks about many of the different elements that I touched on, and it puts them into a program. So it talks about preoperative, intraoperative, postoperative, has education and engagement and information about auditing, so that as a quality improvement program. And what it's intended to do is to bring to you the ability to click through this, to get bullet points of the underpinnings for each of the recommendations. So, for example, if we click on education and engagement, it will take you to a paragraph that explains to you what's recommended in terms of patient education and the patient's role in enhanced recovery. It allows you to click and get examples from different institutions about the patient education material they use for different procedures. And then you can click back to that splash page. You then maybe want to know about the carbohydrate drinks. It takes you to a next page, which about carbohydrate drinks gives you a bullet point paragraph of why it's recommended. It gives you references so that you can use that in your group to make your arguments about why you want to do that. It also, because we wanted to help with implementation, we have an implementation table that gives a timeline for how you can set up your group, what kind of benchmarks and deliverables would be reasonable at different time points. It gives you notes and suggestions on each of these time points about how best to achieve that. And it also gives you examples of standard order sets that are used by some of our experienced centers in colorectal, in HPB, in esophagectomy, and in bariatrics. So examples from centers that have done this and gone through it, and what are they actually doing in real life. So for example, this is Dr. Delaney's at Cases. This is his laparoscopic abdominal surgery enhanced recovery pathway. This is basically his order set for colorectal or abdominal surgery, laparoscopic. And there are other examples there that could give you examples of a good place to start. It may not be exactly perfect for what you want, but it's a good place to start from an expert. The idea here is to help, not just to talk at you and not just to give you another amount of information that can't be used, but to get to that next step of giving you a bit of a jump on implementation. So it basically the the website and also the manual. All the information from the website was culled from a book that we wrote with the ERAS Society, Enhanced Recovery Programs for GI Surgery. And so if you want more details, basically this is the reference book for where the information on the website is. And doing courses, traditional ways of bringing the information to you, courses like this one and the workshop, which will help you this afternoon in a more hands-on way and workshop format. And Dr. Carly runs a course at McGill in November every year, which is with McGill and also has been supported by SAGES. Which has also a great way to come in a multidisciplinary team. So if you come, you bring your anesthesiologist, you bring your nurse practitioner, you bring your PA, and you come up to Montreal in November. It's not the nicest time to come to Montreal, but with global warming, November is looking a lot more like May these days. So I think I'll stop there. I'd like to thank you for coming and for being interested in this. And I would ask you if I could take your questions now and run back to another conflict that I have. So thank you very much.